Okay, thank you very much. I thank the European Gynecology Society for inviting me here and giving me the honor to present the field and the challenges of fertility preservation. This will be fine. Okay. The field of fertility preservation arises for the natural and legitimate desire of women and men, couples, and parents of children to have children of their own and, of course, genetically of their own. So when we talk about fertility preservation, the field is quite extensive, and I will limit my talk to men only. So we deal with cancer patients and non-cancer indications that are treated by chemotherapy or radiotherapy, gynecological patients that are going for operations or suffer from diseases that might interfere with future reproduction, and situation that affects the biological clock, either age-related or accelerated loss of ovarian reserve due to genetic situation or diseases. So our aim is, can we stop the clock and preserve fertility? So this is the challenge. A lot has been studied on this field, and I want to acknowledge Pedro Barry for his recent work of our society together with the ESHRE and fertility and sterility. We had a recent publication on update in fertility preservation, and it was in Barcelona. We had a consensus meeting, and a lot of the things we discussed can appear this, and this was, as I said, published together in human reproduction and fertility and sterility just recently. The potential of fertility is the number of follicles that exist in the human ovaries. And you can see here, and this is from Wallace and Kelsey, the total number of primordial follicles that exist in both ovaries of women during lifetime. And of course, at early childhood and early ages, you can see a lot of follicles in the ovary, but then at the age of 30s, 40, the number declines. And when the total number of follicles goes below 1,000, the woman gets into menopause. So at this stage, there is a limit of fertility preservation because we cannot create, at this stage, oocytes that do not exist. So fertility preservation differs from conventional infertility workup. And the points for consideration are the need, what are the indications, the timing, do we have the right time to do it, not like a patient that comes for IVF and we can tell her come next month. The health status of the patient. We have unique age groups. We have children and we have advanced age that are seeking for fertility preservation. Recent exposure to toxic agents or surgery. What is the efficacy of those technology? And we have different technologies. And what are the safety for the patients and the reproductive outcome? So I'll try to tackle each of these points. So about indications, I will start with cancer patients. So here are a few examples. This is very common Hodgkin lymphoma patients during reproductive age. And you can see that with different protocols, the rate of ovarian failure is completely different. So what is the treatment of this patient makes the difference. For example, those who are treated with low toxicity protocols, there is no need for fertility preservation compared with those who will be treated with toxic protocols. Bone marrow transplantation, highly toxic in all situations, including children. Between the age of 2 or 3, in different reports, more than 70 to 80% ovarian failure rate. So the risk is very high. But there are some situations that the patient will not be sterilized, but will remain with very low ovarian reserve. For example, breast cancer patients treated with chemotherapy at the age of 30s, and you can see here from the work of Partridge that the ovarian reserve parameters like antral follicle count and anti-Mullerian hormone are significantly reduced, so the chances of fertility are also significantly reduced after this. So if we want to put all this together and put it again on the diagrams of the total number of primordial follicles, so those who will be treated by very high toxic agents will remain immediately in ovarian failure, like the bone marrow transplantation. Those who will get, like the breast cancer patients, will remain with small reserve, or those who are children and get half toxic protocol, and they will go into early menopause. And the other needs for fertility preservation can be of patients that actually nothing happens, but they are not allowed to conceive during the next coming years, but she's now at the age of 38, and if she is not allowed to be pregnant for a few years, maybe she will not be able whatsoever. So we can also measure it by anti-Mullerian hormone, and you can see here, cycle by cycle of treatment of chemotherapy, and the level of AMH declines. And there are those who will recover with the medium or low risk, but there are those who will never recover, and the AMH level will remain low. So this is the chemotherapy. I will not talk a lot about radiotherapy, but radiotherapy affects both the ovary and the uterus that might interfere with future reproduction. So when we put all this together, we need to consult our patients, and we do this by what they had in the past. Some of them will have chemotherapy before, or by the ovarian reserve by age, and then what is the toxicity risk of the treatment that they are going to get. And you can see here that alkylating agents, pelvic chemotherapy, pelvic radiotherapy, platinum agents cause a lot of damage, but on the other hand, there are some medications that the mother will come very concerned, but nothing happens to the ovarian reserve after treatment. What about the indications for gynecology? And I will just touch endometriosis. So ovarian reserve in women with endometrioma, you can see several reports showing lower AMH levels and lower antral follicle count and lower outcome of IVF cycles. And this is the way that those with endometrioma will lose their ovarian reserve by lifetime. And this is an indication that we might consider fertility preservation. But more important, are women that are going to surgery, and especially repeated surgery, they are the ones who will end with a premature ovarian failure or low ovarian reserve, and conception can be difficult. So this is a population that we want very much to try to regain fertility. And here you can see what happens after surgery. You can see AMH level, antral follicle count, FSH, ovarian volume, and these are different reports, pre and post-surgery, and many of those parameters are low. So this can bring another population for the need of fertility preservation. What about genetics? There are few genetical situations that will lead women to problems with fertility. One of them is, for example, the Fragile X, that those women have low ovarian reserve. The other thing is we have patients that have from the beginning small ovarian pool of follicles, and because not enough has been created, or those that have accelerated loss of follicles. I'll give you those two examples. Galactosemia, inadequate follicular pool established from the beginning, and Turner syndrome, accelerated follicle loss. So this is an example of operation of a very young child with Turner syndrome. You can see here the ovary that was removed, and these are the fragments that has been taken to future fertility preservation. You can find on many occasions follicles there, but I have to tell you that at this stage we have no babies born after treatment of ovarian tissue freezing for those genetic indications. What about the health conditions of those patients? Also, cancer patients, sometimes you have difficulties to perform the procedure that we are usually do. Maybe because they suffer from anemia or thrombocytopenia that you cannot do anything at this time. They might have mediastinal mass or heart or major airway obstructions, like in this case, and also spine and other organs that can be affected. There is the risk of anesthesia. Many of them will have hypercoagulable states and ovarian metastases when you want to freeze the ovarian tissue. So there is a dilemma for fertility preservation in cancer patients. Is there a risk cutoff? Is it the patient or family decision? Can we delay cancer treatment for fertility preservation? Can we start chemotherapy and postpone fertility preservation? So all these are questions and dilemmas that we encounter them day by day, and now I would like to show the options that we have for fertility preservation. One of them is, can we protect the ovary from the damaging effect of toxic agents like chemotherapy? This is a huge challenge because we first have to know what is the mechanism that causes it. Probably you have heard about the GnRH analog. We are using other medications, and there is extensive studies going on this field, which will not be part of my talk now. But there are the invasive techniques that allow us to try to store fertility, in attempt to store fertility, and this is egg or embryo freezing and ovarian tissue freezing, and I will try to touch them one by one. By this technique, we preserve completely different things. With egg or embryo freezing, we use the mature eggs, or if we do in vitro maturation, the almost mature eggs. But with ovarian tissue, we freeze the primordial follicle. The rest here to try to develop follicles for in vitro is not clinically available at this stage. So what about oocyte and embryo freezing for fertility preservation? So this has been practiced quite a lot of time, and you can see here for cancer indications that this is from a Brigham Women Hospital, and you can see the indication that have been used to store embryos for those patients. These are the results of our unit. You can see also that most of the patients are breast cancer patients because usually you have more time, but some of them can be gynecological patients and hemato-oncology patients. And the results expected is similar to the results of the unit you are working with. So if the results of frozen embryo, the cancer situation will not change the chances of success. And this is the number of cancer of one cycle of IVF for fertility preservation taken from different reports. And you can see that the number of eggs and the number of embryos that you can get by one cycle is very similar if they are cancer patients or not. There is no difference in those studies. But see that the number is not very high. Then comes the problem of the timing. In order to perform an IVF cycle for fertility preservation, especially cancer patients, have a time limit. You have to start treatment fast. So how can you deal with this? So actually today, for freezing, you can start the IVF cycle anytime. You can start it at random. You can start it after ovulation at luteal phase. You can start it at follicular phase, or as conventional by day 2 and 3. And you can see here the first report by von Wolf in fertility sterility, and then just recent publication from the group in Cornell about the random start stimulation on 1,300 patients. And you can see that actually the results are similar. There is no difference in the number of eggs, embryos that you can freeze in those cycles. Yes, it takes 1 or 2 more days and you need a little bit more FSH, but there is really, for the point of fertility preservation, no difference. On many occasions, those patients will come for you for fertility preservation after being exposed to chemotherapy. For example, a patient was treated in another hospital and now she has need to go for bone marrow transplantation, and then she comes here. Yes, I was exposed a few months ago to chemotherapy, but now I'm going to sterilize in treatment. Please preserve my eggs or my embryos. No, this is not allowed. I will not go into the biological reasons for this, but the genetics of those oocytes is completely bad. You can get high abortion rate, high malformation rate, and we do not collect mature or immature egg for fertility preservation in patients recently exposed to chemotherapy up to 6 months. What about different protocols for IVF for those patients? So yes, we want the maximum number of eggs, but there are cancers that are sensitive for hormones, like breast cancer patients and others. So there are 2 protocols that both identical in efficiency. One is administration of aromatase inhibitor, like letrozole, so you can get a similar number of eggs by this stimulation, together with the conventional stimulation, but the estrogen levels will be low. And there is the other protocol that we use more, is again, do the similar normal stimulation protocol that you do, but you add tamoxifen in order to block the estrogen on cancer cells. This, at least, is based on research and not only on the feeling that you have a low estrogen, so probably it's better. So what is the outcome? What can we expect? And now we go to egg freezing. Oocyte freezing has become accepted, not experimental, since 2012. And you can see here the number of oocytes collected and the probability to have a child. And this completely different, there's a complete difference according to patient's age. If you take a young patient at the age of 35 with 20 eggs, more than 90% she'll have a baby. But if she is at the age of 40, their chances are half. And you need much more oocytes, and sometimes you cannot get them in order to preserve fertility. So this I got from Evie in Valencia, and you can see here that for oncological patients, yes, most of the patients that come for egg freezing will have these different ages, so the chances might be good. But the modern world has changed, and now women are seeking to freeze eggs in order to delay fertility for future age, and you can see here some reports in the lay literature that go and freeze your eggs. So when we look on this population, you can see that the average age of those patients is much older, and the chances to have a baby in these cases is lower. So to conclude, egg, embryo, and oocyte for fertility preservation success and the limiting factors. So embryo cryopreservation offers successful and consistent results. Oocyte vitrification is a realistic option for fertility preservation. The more oocyte, the better. But we have limited number of cycles in some of these patients. Some of countries also limit for fertility preservation cycles also for social egg freezing. Age induces decline in oocyte reserve and also quality of age, and is associated with reduced clinical outcome. Age is the most limiting factor. And of course, you cannot do it for children and those, as I explained, recently exposed to chemotherapy. It does not maintain endocrine function. Timing, health condition, and ovarian stimulation should be considered. Another technique is ovarian tissue freezing, and what are the clinical aspects of this protocol. So the advantages, you can freeze a lot of primordial follicles. You can start a treatment for cancer, for example, if you need fast. You can do it for children. It can be performed after initiation for chemotherapy because you preserve primordial follicles. But it's not economic. We lose a lot of follicles, and there's the risk of cancer cells. There are many factors that are involved in the success of this procedure. how much tissue you take, what are the freezing conditions. We believe that slow freezing is the best. The transplantation site, the vascular bed, and other factors, all of these are involved in the success rate. When you put the tissue back, you can put it in a pocket that you make in the peritoneum, like was initially reported by Donez and also by other groups, and you can see here some of these publications. We perform different. We do this, but we prefer for the first point to put it back into the ovary, and these are the publications that reported this. And actually today, I think there is no difference. You can put it here and you can put it there. Our first report on transplantation of ovarian tissue was in the New England Journal of Medicine, and this is the way that we made the transplantation of ovarian tissue here. We tried this. This was not very successful, but this is the way that we perform it now into the ovary. So I will show you, I'll try to show you. It does not respond. Yeah.
Just put the paper.
Okay. Okay, this is a small video just showing the procedure. Everybody can do it. It's very easy. You make a pocket below the cortex, and you can put 1 or 2 tissues inside, 2 sutures, and that's all. Very short, very quick operation. To practice ovarian tissue cryopreservation and transplantation procedure, we should know 2 things. What is the efficacy and what is the safety? So we had the opportunity of monitoring our patient all the time. We gave the consultation, we made the monitoring, we made the evaluation, we performed the ovarian tissue freezing. We saw that the patients were sterilized because we monitored them throughout the years. And after transplantation, we made the IVF and we monitored the pregnancies. So the success rate of this procedure, as we showed by our group, was very high. Endocrine function returned to all patients but 1. We had a IVF cycle that were reasonably successful. We had, at that time, it was published 2016, we have live birth 12, now we have more than 15. But what is important, that under the age of 35, almost 50% of the patients conceived. Not only conceived, some of them conceived 3 times and 4 times, and we have several patients that conceived at least twice, and we had 1 twins. So the efficacy is shown. What about the safety? And this is a difficult issue, and we are dealing with it quite a lot. And I will show you the most difficult cases. These are the leukemia patients. Premature ovarian failure occurs in more than 80% of patients with leukemia. But those patients cannot do IVF because they are very sick when they enter, and most of them will not be able to make IVF. So ovarian tissue freezing is very relevant, but also the risk of contamination with cancer cells is also very high. What's going on here? Okay. So this is the workup that we perform on leukemia patient, and we perform according to the disease different things. And we took ovarian tissue, also the cortex and the medulla of this patient, and we looked on SCID mice for 6 months, and we looked on the histology, and you can see here the follicles, so the freezing and thawing was successful, and we performed FISH according to the disease and specific markers that we found for this patient. And today we have the myeloid panel that you can also find cancer cells in a very sensitive method. And after doing all those things, and this is just now in press in fertility sterility, and this is the mother and this is the child, the first delivery in a leukemia survival after transplantation of cryopreserved ovarian tissue evaluated for leukemia. So having said all those things, at least in Israel, the world result and our single center and other world results, the Ministry of Health in Israel decided that ovarian tissue freezing and transplantation are no longer experimental procedure. So thank you very much for your attention, but I'd like to, one second. I would like to inform you that we have next month our meeting. This was just on the edge of things of fertility preservation. We have our meeting in Vienna in the 5th Congress of International Society of Fertility Preservation, and we expect, do not miss this Congress. And I would like to thank the people working with me. It's a huge group of doctors, scientists, pathology and cancer research doctors and scientists. Thank you very much.